This year's breast and gynecological conference, which has also a little immunology attached to it here in Cairo, is a wonderful meeting where we can combine the expertise of our colleagues of the Middle East with that of the rest of the world. I had the opportunity, thanks to Professor Ghazali, to make a couple of presentations. There are so many areas where we have to discuss. And one of the features this year is that he has put many of the questions into a double presentation. Someone saying why this is important and why it should be applied, and someone saying, I'm not quite certain. And that allows a nice debate, given the pros and cons. So what I was asked to do here was to first look at CDK4/6 inhibitors and whether we should be using the combination of these agents along with some endocrine manipulation in the first setting when patients present with metastatic disease or present even without prior treatment, or whether we can reserve this approach to patients who had first received some simpler treatment, single hormone manipulation, before we go for a combination. And the ABC5 statement of a couple of months ago that is going to be soon published was very clear. The majority of the panel said, let's give this combination first line. But a minority said, no, we don't have the evidence that patients are missing anything. If you look at the data show that in the second line setting, in patients have been pre-treated with hormonal treatment or relapsed during hormonal treatment, these patients do benefit in terms of survival. So if indeed they benefit in terms of survival at that setting, why should we not first start with a simple approach? And we all know, all clinicians know, that some of our patients present with disease that doesn't look really aggressive, and where a simple hormonal treatment might be okay. While for others, we have some anxieties, and obviously everyone says, oh, if there are lots of metastases, or if these are visceral metastases with components that would mean that if we don't do something that we have a rapid response, there was going to be a major problem for the patient, that those should need the combination, but maybe the others can do with a single agent approach and then have a combination later, because there's also so other advantage there. So we don't have a definitive study to explain about that. We will have data in a couple of years to tell us more about this, but for the time being, I think that my word here was, let's think before we prescribe to everyone the combination when they present with metastatic disease. The other point that I'm going to be discussing here with one of my colleagues is very important for the whole world, and especially for those areas in the world where unfortunately there are problems of access to medicines. And this is related to the use of trastuzumab. We know that nowadays we have biosimilar trastuzumab available that has decreased the cost a lot, but nevertheless, 12 months of treatment in the adjuvant setting with trastuzumab compared to 6 months has been the subject of many studies, several of which have been now fully published and republished and extensively analyzed. The overall consensus seems to be 12 months is what we should do. However, it might not be true. My position at the discussion will be to defend the idea that 12 months is the approach, because we have not been able to, according to statisticians, convincingly demonstrate that 6 months is just as good and just as safe. But if we look at the data, it seems that for quite a few patients, we can do with 6 months. And this is very important because it reduces the impact of treatment time and the impact of treatment costs by half. So we have to think twice there. I will defend, of course, the official position, but Professor Valentina Guarneri, my dear friend, will show that maybe we have to think twice.